All right. I'm up here again only to introduce our awesome last speaker of the day, Lucy Logan Spears. She is a fantastic physician assistant with our Blood Disorders and Cellular Therapy Center at the University of Colorado. After graduating from Colorado College with a BA in philosophy, she spent several years working as a ski instructor, wilderness trip guide. That's cool. And an EMT before returning to school to train as a physician assistant. She first became interested in malignant hematology while attending PA school at the University of Colorado and started her career as a physician assistant with our program in 2020. Lucy is co-chair of the Allogeneic Stem Cell Transplant Committee and guest lecturer of hematology at the Colorado CHA PA program, and writes all sorts of cool guidelines for our group and does amazing things, and gets a group of physicians together that often have interesting discussions every month. That's the allogeneic group. But yeah, thanks for everything you do for our program. Thanks for talking today.
All right. Thank you, Erin, for the introduction. So am I supposed to wrap things up by 3:15? Because I think okay. It's gonna be a little. And thank you to everyone who stuck it out to the end of the day. I appreciate it. So like Erin said, I've been working with the Division of Hematology for about 3.5 years now. And when I first started, I found the topic of transplant, particularly allogeneic stem cell transplant, to be one of the more challenging things that we do. I feel like there's a lot of different moving pieces that each have their own kind of specific considerations, and fitting everything together can be overwhelming. So what I was kind of trying to do as I made this presentation is give kind of a cohesive view of the whole process, from like somebody starting to be evaluated for a stem cell transplant into the survivorship phase. So objectives: understand why we do both types of stem cell transplants, the evaluation process prior to transplant. Going to talk a little bit about HLA matching, pros and cons of conditioning regimens, and then early and late complications of stem cell transplants. Okay. So going to use a case study, this young woman, Mary, to take us through the whole process that we'll walk through in this presentation. So she is 28 years old, unfortunately has recently been diagnosed with AML with an unfavorable TP53 mutation. However, now in remission after undergoing intensive induction chemotherapy. So at this point, would need further treatment, like my colleagues have talked about a little bit, to consolidate her remission. Otherwise, the likelihood of relapse is high. So she is a great candidate to evaluate for an allogeneic bone marrow transplant. So going back to the background a little bit, what are the main reasons, the primary indications that we might prescribe an allogeneic stem cell transplant? It really does vary based on the disease state. The main one that we would use for malignant hematology disorders at our center is the graft versus leukemia, or the graft versus tumor effect. So I can thank Heather, because these words I've taken almost directly out of her mouth. But you can imagine when we give someone conditioning chemotherapy with the end goal of either ablating or reducing their own immune system, and then we've replaced their immune system with someone else's healthy immune system, healthy bone marrow. Once engrafted, that healthy bone marrow, we hope, will then be able to surveil and look for any recurrences of the patient's disease, and kind of knock it out as it might arise in ways that their own immune system would not have been able to do. So we use this indication most commonly with acute myeloid leukemia, ALL, as Erin said, later lines in the non-Hodgkin lymphomas, and then very rarely as like a later line therapy in myeloma. In every type of bone marrow transplant, the goal is to replace damaged or malfunctioning bone marrow with healthy bone marrow. So whether we damage the bone marrow ourselves with chemotherapy or whether the patient is going into the transplant with some residual disease, the goal is to give them a healthy functioning bone marrow after the transplant. For autologous stem cell transplants, the big indication is that it allows intensive treatment with high doses of chemotherapy. The thinking there is that, we want to give a patient so much chemotherapy that their disease will be treated, but we don't want to give them so much to the point where they won't ever be able to recover. So it allows us to give a large dose of chemotherapy and then rescue them with their own bone marrow. We often use this as well for aplastic anemia, just to restore hematopoiesis, and then more in the pediatric population for things like congenital metabolism disorders or immune deficiencies. Okay, so just want to touch briefly on auto transplants, and then the rest of the presentation is mostly allos. But we use these most commonly for lymphoma, for myeloma, and then other solid tumor malignancies. So like I was just saying, basically just a way of allowing us to give the patient a massive dose of chemo to ablate their bone marrow and then rescue them with their own healthy hematopoietic stem cells. In these cases, no immunosuppression is needed and there's no graft versus host disease because, of course, it's their own bone marrow. For myeloma, we usually use melphalan conditioning at myeloablative doses. And these patients generally are able to go home sooner, have less frequent follow-up, and they're able to leave the hospital without their central line. Lymphoma is a little bit more intensive. We'll use similar conditioning regimens to those that we use for allotransplants, regimens that are myeloablative. And then these patients do have to stay locally a little bit longer and have more frequent follow-up. Okay. So next we will talk about transplant eligibility, what patients are candidates for a transplant and why. So this is a pretty complicated assessment process that's performed by an interdisciplinary team that includes, of course, transplant physicians, but also a team of coordinators, nurses, sometimes researchers are involved, psychologists are involved, and they'll also meet with our social workers. Some of the things that they consider when they're evaluating a patient for transplant are factors related to their disease. So transplants are obviously not a benign intervention. So are the results, will they be better than other non-transplant options? Or have other adequate options of treatment already been exhausted? And then something to think about, this is a varying line of therapy depending on the disease state. So like Carrie was saying, in AML, it's an earlier line. Myeloma would be a much later line of therapy. These patients also get a psychosocial and functional evaluation. This includes a very detailed history, like a psychological history, their performance status. We also ask about drug allergies, infection history. The reason for that is that transplant puts them at very high risk of infection, especially the early stages. So, not ideal if they're allergic to multiple different types of antibiotics or if they have potential for reactivation of infections. Same thing with physical exam, looking for potential sources of infection. And then we want to do labs and imaging, looking at the functioning of basically every major organ system. We also ask them about their caregiver support, what their support network locally is like. And then we include questions about tobacco, drug, and alcohol use. So some of the limiting factors, it really depends on the physician and the center and what their historical practice has been. But kind of traditional literature wise, the cutoff for giving an allogeneic stem cell transplant has been anywhere from 55 years old to 75 years old, just depending on what else they have going on, including comorbidities, particularly pulmonary comorbidities, cardiac comorbidities, renal comorbidities, and prior hepatic issues. We do worry about their hearts just because cardiac reserve makes a difference. Most transplants are associated with some degree of subacute cardiac injury. So obviously, like if they have a history of heart failure or cardiomyopathies, it could put them at a lot higher risk. Same thing with their kidneys, just at baseline, we give people a ton of nephrotoxic agents. So we want to consider what their like baseline renal function is before going into the transplant. We also need to think about donor availability, and we'll talk about this more in a little bit. But the main sources are umbilical cords, family, or unrelated donors. Very important for them to consider their plan, not only while they're in the hospital, but after their discharge. They need very close follow-up. So we think about like who's going to help take care of their families, what are they going to do about work, who will drive them to and from their appointments, what psychosocial support do they have. And then one thing that I thought was worth mentioning as I was writing up this presentation was that, there are systemic inequalities in our country that make getting a transplant just more feasible for some people. And I think that's important to keep in the back of your mind. So going back to Mary, fortunately, she lives locally. She has a very supportive community. She has multiple caregivers, no comorbidities because she's in her 20s. So she is a great candidate for transplant. And now we'll talk about how we match donors and recipients and a little bit of an introduction to HLA. So finding a donor really comes down to the appropriateness of HLA matching. How they determine somebody's HLA type is a process of molecular typing. The most common, according to my research, is called high resolution typing. Don't ask me how it works. Heather might know. But it looks at sets of alleles and the same protein sequence at the HLA molecule's specific antigen binding site. So this is a very basic picture of what this might look like, but I think it helps to just start getting how it works into your head. Like you can see on the patient on the left, the little shapes on the outside of his cell represent his HLA type. And, the donor on the right matches him and the donor on the left has different shapes. So she would not be a match. Okay, so getting a little bit into the science of HLA stands for human leukocyte antigen. This is a system of genes on chromosome 6. These genes help the body recognize what is self, what is not self, and they're also responsible for regulating your body's immune response. Interesting thing about HLA is that it's the most polymorphic genetic system in humans, with the maximum variation concentrated in the antigen binding groove. I've never heard it called the taco before, but I like that. And then if you've had immunology before, this is the human version of the MHC system. So here's a picture. Okay. So this is chromosome 6, and you can see here all of the HLA genes. Genes A, B, and C correspond to class 1, and these are expressed on the surface of all cells. And then genes DP, DQ, and DR are encode for class 2, and these are expressed on the surface of professional immune cells, so like B lymphocytes, antigen presenting cells like dendritic cells. If you are a more visual person, this is a depiction of class 1 and 2 molecules. These are MHC, so not the human version. And you can see the peptide binding cleft, the taco, where the genetic polymorphism is most concentrated, is up here on both of these molecules. So donor suitability depends on their HLA haplotype. So HLA genes are very closely linked, fortunately. They're inherited as an entire haplotype. So you get one type from one parent and one type from the other parent. They're not like mix and match via a Mendelian inheritance pattern. So if you've seen before the Punnett square, you only really have 4 options that you can get between the 2 different haplotypes that each of your parents has. So in general, the main thinking behind wanting HLA matching is to avoid A, graft rejection, and B, graft versus host. Some degree of HLA mismatch can be beneficial, and we'll talk about that a little bit more later. But in general, you want at least a half match. So the degree of the match we've seen correlates with the graft survival rate, and then this drops with each degree of mismatch. So all prospective patients undergo HLA typing pretty much as soon as we are thinking that they might need to get a transplant, because it does take some time. Another thing worth mentioning is that the urgency of finding a donor does matter. So, sometimes we have to weigh the benefit of wanting to start a transplant sooner before a patient might relapse versus waiting to find the perfectly matched donor if they don't have someone appropriate in their family. Historically, the ideal match for an allo transplant is a matched sibling. So they have 25% chance of being identical and then 50% chance of being half matched. So having like one matching haplotype, one unmatched. So you can see here that the haplotypes are represented by different colors, and you can see the HLA genes, ABC, DR, DQ, and this is the patient. So he's received one haplotype from mom and one haplotype from dad. Looking at his siblings, there's a full match over here, and then we have a haplo match here because they have the red. He also has the red, and a half match over here who also has the haplotype from mom, and then the sibling got the 2 other haplotypes from each parent. As I was getting this presentation together, I was seeing in all of my reading, like matched sibling is the best choice. And I feel like we're moving away from that. So I was talking about it with one of our transplant physicians, and he was saying like, oh, it really just depends on the patient. Like there's so many factors that go into it. And one thing that he mentioned that I haven't heard of was that sometimes what we've been doing is if a patient is older, like maybe not as fit in their 70s, and they do have a matched sibling, we might instead go with a younger matched unrelated donor just because their immune system is more robust. We also consider the status of their disease and the desire of the graft versus disease, graft versus leukemia effect. So like we said, the preference historically is the matched sibling, followed by an 8 out of 8. So the numbers are just referring to the different genes. Matched unrelated donor, followed by a mismatched unrelated donor versus a cord versus a half matched donor. So matched unrelated donors, they look a little bit different than matched siblings because they might have the same genes, but they might not necessarily have the same haplotypes, if that makes sense. So they might have the same genes, but mixed up on their 2 sets of chromosomes. Matched unrelated donors have similar survival rates as matched SIBs. Unfortunately, a little bit more morbidity, including increased acute and chronic GVHD rates, probably just due to that additional little bit of genetic changes from mixing up the genes on the chromosomes. Challenges of finding a matched unrelated donor is that there is a disproportionate representation of ethnic and racial backgrounds in our donor registries. And this is just because people who have historically lived in different parts of the world have their own pool of haplotypes. So we have the easiest time finding matches for white patients, and then increasing challenge with people of color. Interesting of note, identical twins. If a patient has an identical twin, then they're like an exact genetic match. So these patients would not require any immunosuppression, and they also do not have any risk for GVHD. However, they have a higher risk of relapse due to a lower graft versus tumor effect. The way I think of it is that it's basically like you're giving them closer to an auto transplant than an allo transplant. So, if you were in AML remission getting worked up for an allo, I don't even think that they would choose an identical twin if you had one. They also use umbilical cord blood. Some of the advantages of cord blood is that it's easy to get, it has a lot of hematopoietic stem cells in it. There's a larger donor pool, and then we've seen decreased rates of GVHD. Some of the cons, increased rates of graft failure. We see sometimes delayed engraftment. And then if the patient does end up needing like a stem cell boost, the donor is only available for the one donation of cord blood. We also use, in some cases, haploidentical donors, so a half match. The advantages of this is that patients, if they have multiple siblings, generally have options in their close family, or like each parent would be a half match as well. And then the negatives is increased rates of GVHD and increased mortality risk. And then sometimes they surprise us and do combos like cord, haploidentical, cord, and other things. So again, just very complicated. And the transplant physicians take a lot in when they're making the decision about what type of graft to use. So fortunately, Mary has 4 siblings, 2 of whom are matched siblings. So they share both haplotypes. One of them lives locally, so they're going to donate, and we will plan to go ahead with her allotransplant. So now that we've decided her donor, she will get admitted to the hospital, and we'll give her some conditioning therapy. So previously, when we chose conditioning therapy, the practice used to be that we would try to give patients the most myeloablative regimen that they could tolerate. However, more recently, we have seen, like I talked about earlier, that the graft itself has the graft versus tumor, graft versus leukemia lymphoma effect. So in itself is part of the treatment for their disease. And this is allowed for just more use of reduced intensity regimens that aren't so toxic. But like everything has to be weighed with the risks of not giving a myeloablative regimen, so maybe increased GVHD. Also important to keep in mind that the graft versus tumor, graft versus leukemia effect only kicks in after engraftment, because prior to engraftment, it's not a competent immune system. So you want to give these patients enough myelosuppression to prevent them rejecting the transplant. If there's any residual disease, you want to destroy the underlying malignancy. So you always, it's like a balance. So you always think about graft versus tumor effect versus prevent graft versus host disease versus prevent relapse. And of the myeloablative conditioning regimens, the goal of these is to completely knock out the bone marrow, destroy the hematopoietic stem cells. These regimens cause profound pancytopenia that lasts for at least, at minimum, 2 to 3 weeks after receiving the conditioning. And then these are generally combinations, various combinations of high dose Cytoxan, busulfan, fludarabine, thiotepa, and then we'll generally throw some radiation in there. And with these regimens are built in the non-chemotherapy agents that we need for the transplant to be a success. So your immunosuppressive agents to prevent graft rejection. Okay. And I liked this diagram for showing what happens to the cells before, during, and after transplant. So the more myeloablative regimens, you see before the transplant, the patient has their normal cells, and then there's also the leukemia cells in green. On the more myeloablative end of the spectrum, the conditioning therapy will knock out all of their cells, or maybe there'll just be a couple left. And then as the immune system, the new bone marrow comes in, they'll have all of the donor's hematopoietic cells, or maybe just a couple leukemia cells or their own healthy hematopoietic stem cells left. So for non-myeloablative reduced intensity regimens, like we were saying on an earlier slide, these are a little bit more permissive. So these have become more popular in the age of knowing about the desired graft versus tumor effect. Often will be combinations of the same chemotherapy agents, just at reduced doses. The pros of this is that it allows for a more inclusive pool of patients who are able to get stem cell transplants. So, pushing that age cutoff up into the 70s. I don't know if I've seen anybody in the 80s, but potentially. And then cons, we see increased rates of graft versus host disease, obviously, just because there's more potential for the original immune system to stick around, and increased risks of relapse. So down here, you see the non-myeloablative conditioning, normal cells, leukemia cells, and then the conditioning gets most of it, but not all of it. And as they have immune reconstitution, you see the donor cells, leukemic cells, and the recipient's original cells. And the hope here is that the graft versus tumor effect kind of contains the leukemia cells. Just want to touch on TBI, since we do this frequently as part of our myeloablative and non-myeloablative regimens. So this has been part of conditioning since the early days of stem cell transplants. We generally divide it up over a couple of fractions just to reduce toxicity. The advantage of doing lower doses is that it won't be as toxic, not as many side effects. But, like anything else, increased risk of the disease recurring or the graft failing. At higher doses, we see decreased graft rejection, decreased relapse, which are good things, but increased treatment-related mortality and increased toxicities related to the radiation. So some common toxicities of conditioning chemotherapy, we very frequently see mucositis. This can range from mild to more severe. The treatment kind of depends on what their symptoms are, but stepwise, we can start them with topical treatments like a mucositis mouthwash, good oral hygiene, then kind of amp up non-opioid pain medications, opioid pain medications, and our patients with most severe mucositis often end up needing patient-controlled anesthesia pumps. We often see a lot of GI symptoms, so your nausea, vomiting, diarrhea. For this reason, they actually build the antiemetics into treatment plans now, so they get them like before every dose of conditioning chemotherapy, or they'll get nightly Zyprexa to prevent nausea. Later on, after the conditioning chemotherapy, patients commonly need volume support with IV fluids. They might need their medication switched to IV, and then they might need IV or scheduled antiemetics. We see a lot of diarrhea, and this one we want to keep a very close eye on because we are concerned that it could be an infection, but it could also be regimen related. So we'll give them weekly stool testing for infections, and if that's negative, they get antimotility agents. Infertility conditioning regimens are generally pretty myeloablative. So we would hope that they've addressed this issue earlier, like when they were diagnosed, but just important to remember. And then really chemotherapy has broad toxicity profiles, right? But the big ones we think about: peripheral neuropathies, pulmonary toxicity, hepatic toxicity, renal toxicity. Every organ can be affected. So for Mary, we will have chosen a myeloablative conditioning regimen. Why have we done that? She's very young, in her 20s. She's in good shape. She has no comorbidities. So for her, we would do something like Thiotepa 10 mg per kg, busulfan 9.6 mg per kg, or fludarabine, or with fludarabine 150 mg per meter squared. And this is a pretty common standard of care myeloablative conditioning regimen for patients under 40. In the hospital, She gets a little bit of nausea, totally treatable with PRN antiemetics, otherwise does just fine. Okay, and then I wanted to touch on this because this is something I was very confused about when I first started. Like, how do they actually get the bone marrow out of the donor, like into the patient? What happens to it on its journey? All those things. So the essential product that we are transfusing into the patient is hematopoietic stem cells from an HLA matched or partially matched, like we've talked about, donor. So if it's a cord, we have these stored by cord blood banks that collect these and then keep them until needed. If you've been pregnant at all in the last few years, you've probably seen many ads for commercial cord blood banks. They're not used for clinical purposes like this. The one that's the most common is Be the Match. And Be the Match is also for adult bone marrow donors too. If the bone marrow is collected from an adult locally, it is peripheral blood. Prior to donation, the bone marrow is stimulated with GCSF just to increase cell growth. And this increases levels of hematopoietic stem cells in their peripheral blood, so mobilizes the hematopoietic stem cells out into the periphery by about 1,000 times. After they collect the blood, they check it for the amount of CD34 positive cells, and CD34 is just a cell surface marker of hematopoietic stem cells. If there's not enough CD34 positive cells, we worry that there might be slower bone marrow reconstitution in the recipient. So the patient or the donor might end up having to come for another day of bone marrow donation where they collect more stem cells. And then in some cases, just worth keeping in mind, they do CD34 negative selection to remove T cells. So cases probably where graft versus host disease is a higher risk. And they do this all via apheresis, like we've talked about in earlier presentations, but just a machine that is able to remove certain types of cells and then return the other cells back to the body. And then FYI, like just came up as I was making this, you'll see on our paperwork from stem cell collections that they're called peripheral blood progenitor cells, but in reality, it's actually a mix of progenitor cells and hematopoietic stem cells. Seen this many times today, but it's these top 3 that come in the bone marrow transplant. So if the cells were collected in our infusion center from a local donor, they must be collected on the day that the bone marrow transplant is planned, and they will be delivered freshly to the patient's room. They get infused through an IV catheter, just like any other blood product. We do worry about reactions with stem cell infusions, especially if the product has come from like a cord blood bank or from a donor that's far away, because they use something called DMSO to cryopreserve the stem cells, and that can cause some reactions. But the big things we look out for would be fever, cough, nausea, vomiting, flushing, shortness of breath, and then like worst case scenarios, hypotension, tachycardia. But after the cells are infused, they then migrate on their own to the bone marrow and set up shop. So in Mary's case, her sister, her fully matched sister, comes to the clinic or the infusion center to donate her bone marrow. They then deliver it. It has enough CD34 positive cells in it. They deliver it right up to her room and she gets the infusion. Before the infusions, she gets her pre-medications of Tylenol and Benadryl just to mitigate any reaction, and she does great. Okay. We'll talk next about complications of bone marrow transplants, early and late. So I thought this image does a good job kind of breaking down visually at what stages we're most worried about what different complications. So you can see Day 0 to around day 28, it varies on the type of, based on the type of conditioning regimen. But that's when they have their profound pancytopenia. So you're worried about complications related to that. So, your bleeding, your infections. As we get farther out from the transplant, we start to worry more about graft versus host disease, especially as the donor's stem cells kind of constitute themselves. And then we continue to worry about infection. So I would say probably the biggest concern throughout this process, especially in the inpatient setting, is infection. While they have that pancytopenia, neutropenia, the risk of infection is very, very high. And this is often at least 4 weeks, which is why, one of the reasons why they have to stay in the hospital for so long, just for close monitoring and allowing for intervention if needed. But that said, even after they've been grafted, they remain immunocompromised for, weeks, months, years, and we consider that functionally neutropenic. So they may have neutrophils, but, they don't have all the experience of a mature immune system. So some common infections that we see more frequently that are not as common in other populations. Under the umbrella of bacterial, we see a lot of central line infections. We see a lot of gram-negative rod infections, so your Pseudomonas, and we see a lot of bacteremias. Fungal, we often see invasive fungal sinusitis, and then we've seen a couple of disseminated fungal infections as well. Under the viral umbrella, we worry about reactivations of prior viral infections, and then we monitor adenovirus, CMV, and Epstein-Barr virus. For these patients, we keep them on preventative antimicrobial treatment to hopefully prevent some of these infections. So we'll give them acyclovir, something similar to prevent viral infection, viral reactivation. We'll give them Levaquin or something similar to prevent bacterial infection, fluconazole for fungal infection. We'll give them Bactrim to prevent PCP pneumonia, and then some of them get Letermovir. They also get very close monitoring multiple times a week in the clinic. And this is after they're already a month out from their transplant because they're safe to discharge. And then they have very, very strict return to clinic precautions. It's not uncommon that we see patients up to 100 days post-transplant in and out of the hospital. Okay, and then I also liked this image for showing what stages we worry about different types of infection. So you can see when they're neutropenic, fungal infection is a big concern, for example. After they've engrafted, CMV, zoster. And then this diagram just shows all the different ways that they're vulnerable to infection, that they have a net immunosuppression. So you could give a whole nother presentation on GVHD, but this is a commonly seen cause of treatment-related morbidity, mortality, and on a very basic level caused by the donor's T cells attacking the recipient's cells. So in the acute phase, this is generally less than 100 days after a transplant. The organ systems that are involved will be skin, the GI system, and the liver. In the chronic phase, generally over 100 days after the transplant, a little bit broader involvement, we'll see skin, mouth, liver, lung, eye, joints, and GI. So how we prevent GVHD, part of it is the donor selection that we already talked about. We also give all of our allotransplant patients a calcineurin inhibitor, so your cyclosporin, for example. And the way that these work is they block the T cell signaling cascade. So as soon as the T cells start trying to ramp up, get excited, they say, no, we're not doing that. The challenge of these drugs is that they require periodic monitoring just to make sure they're within a certain therapeutic range because they do have some toxicities. We also give patients anti-metabolites, so MMF, methotrexate, and these block proliferation of activated lymphocytes. And then in some patients, particularly our haploidentical transplant recipients, we give them Cytoxin after their transplant, and this just suppresses the response of alloreactive T cells through mechanisms not totally known, supports the development of regulatory T cells. Continuing with the treatment-related morbidities, mortalities, this is the last slide of this. So we also see acute injury to various organ systems. Big ones include the kidneys, the liver, the lungs. Kidneys they can be affected by some of the medications we give, the calcineurin inhibitors, also susceptible to infection like pre-renal injury, sepsis, volume. Lungs, patients, very common to get pneumonia. They can also get engraftment syndrome, more rarely bleeding into the lungs with your diffuse alveolar hemorrhage. And then lungs can be affected by GVHD. And then liver, we always worry about sinusoidal obstructive syndrome, veno-occlusive disease, could also be affected by infection or GVHD. Psychiatric wise, patients can get a little bit of delirium when they're in the hospital just due to being cooped up in there. And then I guess something with the conditioning chemotherapy can contribute to that as well. And then depression and anxiety for obvious reasons. We commonly see malnutrition for a multitude of reasons. They're deconditioning, if they're having GI issues, nausea, vomiting, diarrhea, if they're having decreased appetite, if they have mucositis and can't eat. So not uncommon that patients will require a feeding tube or IV nutrition. Okay, so going back to Mary, she tolerated the transplant pretty well, got a neutropenic fever on day 15. We sent for workup, blood cultures, urine cultures, respiratory viral panel, chest x-ray, pretty standard workup for any neutropenic fever. Empirically treated her with cefepime, gave cultures some time to grow. RVP was negative, no growth on the cultures after a couple days. So she was continued on cefepime for a short course, and then we were able to switch her back to prophylactic Levaquin dosing. So a little bit about life after transplant. Their complications and mortality are highest in the first year. And non-relapse related causes of mortality include GVHD, chronic GVHD, infection. Unfortunately, cases of secondary cancers can occur. And then one study that I saw of 10,000 patients, the 10-year overall survival rate was 85% in those who did not relapse, like disease relapse in the first 2 years. So I actually thought that was pretty good considering everything these patients go through. Okay, so I wanted to end on a happy note. Mary, she has her regular disease assessment with bone marrow biopsies, negative 1 year, 5 years, and she is able to go back to her normal life and regain her functional status and is very happy and lives for a very long time. The end. Questions? Everyone's like, we're ready to get out of here.
Does anybody have any questions? Lucy, that was a really wonderful overview of the entire transplant process. I mean, everything that you went over, it's quite remarkable that you actually did it in like 45 minutes, which is quite amazing. But yeah, I mean, to listen to you talk about all of the things that, the patients go through, obviously, to get through a bone marrow transplant, but all the preparation and, I think everything that, we do as providers and the coordinators, the doctors, the blood bank, everybody that's involved to perform a transplant, it's just quite amazing. I think we don't think about all those pieces, you know, our job, we're like laser focused on getting these patients through the transplant process. And I'm always so, you know, so proud of our APP team in navigating that whole experience with these patients, because it's intense, it's highly acute. They go through so much. And I think, you know, we as providers, and especially our APP team, we go right through it with them, you know, and like I said, just laser focused on doing anything and everything we can to get them through it. And it's the whole process, I think, is quite remarkable. And to see that, you know, the ending slide of really the outcomes are really great. And we've been able to expand the types of transplants we do, give more people an opportunity to get a transplant and potentially get cured from these, you know, deadly diseases that we didn't have before. So I think, you know, there's so many new drugs, so many new things going on in oncology care in the blood cancer world, but we've certainly made so much progress in the world of stem cell transplant also. So it's just a really great job. So anybody else have any other questions? I don't see any online.